So our next speaker, Dr. Lindsay King, is visiting us from Duke, so it's just a pleasure to have her. She's a transplant hepatologist. She has a strong clinical interest in autoimmune hepatitis, and one of the reasons we brought her, but also the variant syndrome AIH with PBC as well as liver transplantation for that matter. She's going to speak to us about women's issues in AIH, but also in pregnancy. So please join me in welcoming Dr. King.
Thank you all so much for having me here today. I'm really excited to be a part of this conference, and it was really neat last night to learn about this organization at dinner, and I'm excited to share what I've learned with my patients, and hopefully they'll join this group and participate in this conference in the future. So over the next 20 or 30 minutes, I'll talk to you guys about pregnancy and some women-specific health issues within autoimmune hepatitis. I'm going to focus on pregnancy as a large part of this talk. I'll also talk about breastfeeding or lactation, talk about contraception, and then healthcare maintenance, pap smears, and some bone health. I was talking to one of my patients, and I said, well, what do you think I should address in this conference? And they said, well, isn't autoimmune hepatitis a woman's disease? And in part, they're right. As you've heard, it is a female-predominant disease with a female-to-male ratio of about 4 to 1, but I have plenty of male patients. There have been a couple studies looking at gender differences in autoimmune hepatitis and the way patients present. And what we've learned is women tend to have more other immunological disorders, such as thyroid disease or rheumatoid arthritis. One study showed a better overall survival in men compared to women. This was not liver-specific survival, and it was only one study, but I think it's something to look at and try to understand better in the future. So moving on to pregnancy, as I was preparing for this talk, I actually saw a patient in clinic who was 35 years old. She'd been diagnosed in February with autoimmune hepatitis. She was jaundiced with a bilirubin of about 14 when she presented. She was tired, had aminotransferases in the 700 range, had a biopsy. It showed autoimmune hepatitis. She did not have cirrhosis on the biopsy. We had gotten her on Azathioprine and prednisone. We were tapering the prednisone, and she was down to about 15 milligrams, and we spent the majority of the visit saying, let's work to get off prednisone over the next 4 to 6 weeks, and how we would monitor labs. And as I was about to leave, I said, do you have any other questions? And she said, well, I'd like to try to get pregnant with my second child. Can I get pregnant? What do you think about this? Are my medicines safe? And these are really the questions I get. Conception. People want to know, is their fertility preserved? And the answer is, in general, yes. Unless you really have decompensated or advanced cirrhosis and scarring in your liver with complications related to cirrhosis, in general, fertility is preserved. Sometimes earlier in the presentation of the disease, before the disease is actually under control, fertility can be affected, but in general, women can get pregnant who have autoimmune hepatitis. As you get more advanced disease and decompensated cirrhosis, the hormones that govern menstrual cycles are altered, and nutrition also affects this. And patients can have anovulatory cycles or irregular cycles or even lack of periods. However, irregular cycles still don't mean that the patient can't get pregnant, so we still have to think about contraception as well. What's the maternal risk? There is a risk of flare of disease. We see this in the postpartum period mostly, and I'll go through that with you. What's the risk of fetal complications? We do see an increased risk of prematurity and fetal loss. That's more with advanced liver disease. And then, are the medications safe in pregnancy, and how should we dose them, and should we continue them? I think the most important thing when I'm working with my patients is preconception counseling. I'd rather know that my patient's going to become pregnant. I'd rather give them advice before pregnancy. And so I try to address this early on in the course of the disease in my patients who are of childbearing age. I don't address it right away. We're just focusing on the new diagnosis, but I do try to address it fairly early. And you have to weigh the relative value of parenthood to the patient as well as the risk, and you have to individualize the risk to that patient. We see the most risk to the mom in patients who have cirrhosis, which is just advanced nodular scarring in the liver. There is a small risk of death. The risk in cirrhosis is decompensation or progression of the disease. So patients developing ascites or fluid in the belly or confusion or GI bleeding. We use the MELD score, or the Model for End-Stage Liver Disease score, to predict need for transplant and liver disease in general. You can Google the MELD score, you put in your creatinine or your kidney function, your INR, or how well your blood clots, and your bilirubin, and you get a number. There was one study looking at all comers with cirrhosis. Now, most women with cirrhosis who get pregnant have autoimmune hepatitis, so the majority of patients in this study had autoimmune hepatitis. And what they saw, if the MELD score was 6, there were no complications. But if the MELD score was greater than or equal to 10, that's when they saw complications. I really work with the patient to try to stabilize the underlying disease prior to pregnancy. I'll show you guys some data on that later. But if patients are in remission on a stable disease regimen, the patient and the fetus tends to do a lot better. If patients have cirrhosis, we'll assess for varicose veins in the esophagus. I'll show you in a minute how those can grow and why during pregnancy. And then I try to identify a high-risk OB. And I try to send my patients to the obstetrician before they're actually pregnant, so they meet someone and have a relationship with someone before they get pregnant. So the physiology of pregnancy in women actually mimics the physiology of end-stage and advanced liver disease. You have about a 30% increase in your blood volume, about a 40% increase in your heart output, and your heart rate increases in pregnancy. You actually have decreased blood pressure, and that's because the blood vessels actually dilate in pregnancy. So what we see is an increase in portal inflow or blood flow to the liver. In patients who have cirrhosis or nodular livers, you have scarring here, and that scarring compresses these sinusoids which filter blood in the liver. So when blood flows from your intestines into your portal vein, it faces more resistance. And so that's why we get portal hypertension. It's just really a plumbing issue in part here. We also see in cirrhosis with the increased heart output and blood vessel dilation that there's increased flow. So you have increased flow into the scar-resistant liver, and that's how people get portal hypertension. And that leads to these portosystemic collaterals, or blood finding other ways rather than going to the liver to get back to the heart. And that's why we see varicose veins. So when women get pregnant and they have increased blood volume and this blood vessel dilation, we can see a growth of these varices and an increased risk of variceal bleeding. I try, if my patients are going to get pregnant and they have cirrhosis, to do an endoscopy before they get pregnant and try to manage the varices before. It has been shown to be safe in the second trimester to do the endoscopies if needed. And then we've talked about liver tests. Dr. Holden addressed this a little bit already, but I think it's nice and important to know what's normal just with pregnancy. So your alkaline phosphatase actually increases during pregnancy. The placenta and fetal bone produce this, so in the second and third trimester, it's normal to see that. Your hemoglobin actually decreases, and that's just because the expansion of general blood volume, and your albumin can decrease. But what stays the same are the ALT and AST, so we can follow those during pregnancy. And then a little bit about autoimmune hepatitis and the T cells that Craig talked about earlier. So your immune system is composed of T and B cells. And what happens with different stimuli in your body, hormones, they differentiate into T helper 1 or T helper 2 cells. And normally in women in the lower estrogen state, this favors a T helper 1 response, which leads to the production of pro-inflammatory cytokines. So this is what we see in women with autoimmune hepatitis. In pregnancy, in this high estrogen state that we have, or also in males who have testosterone, we see you going to a T helper 2 response and antibody production. And this actually favors tolerance. So what we see during pregnancy is that women are very tolerant. They have a fetus in them. And we actually can see control of the disease as pregnancy progresses. But after pregnancy, as estrogen drops, we can see a flare. So when I'm counseling my patients, I look to data and studies, and I also look to societal guidelines. The American Association for the Study of Liver Disease has produced some guidelines on autoimmune hepatitis in general, and they have a small section on pregnancy. I would say these guidelines are from 2010, and I think they're in need of updating. They do say that pregnancy is well tolerated. The risk is prematurity. Fetal loss is higher than in normal mothers, but similar to other mothers with chronic diseases. They suggest counseling patients regarding the uncertain safety of azathioprine. I think counseling is very appropriate, but they go on to suggest maybe we should stop the azathioprine which I actually disagree with, and I'll give you a little bit of data on that in a second. They do say anticipate postpartum flares, and I completely agree with that. So Europe also produces guidelines. They've been updated as recently as 2015, and they give you a lot of data on their guidelines. And they suggest that you should continue azathioprine with prednisolone, which is the equivalent of prednisone. They say mild flares can occur in the first trimester and then postpartum, should anticipate those. And then mycophenolate mofetil, which is another agent we do use in autoimmune hepatitis, is contraindicated, which I completely agree with. So the largest study we have is out of King's College in London. It looked at 81 pregnancies and 53 women. 60% of the women were in biochemical remission for a year prior to pregnancy, meaning their liver enzymes were normal. And 40% of the pregnancies actually occurred in women who had cirrhosis. And what they saw was the live birth rate was 73%. It was lower in individuals who had cirrhosis. The prematurity rate was 20%, which is higher than the normal population. About 11% of the babies were admitted to the equivalent of a neonatal intensive care unit. And this was more likely if the mom had cirrhosis or the mom had a flare of her disease during pregnancy. And the maternal complication rate was 38%, and that was mainly disease flares. So about 33% of the mothers flared. It was more likely postpartum, and it was more likely in women who were not on therapy. There were 4 deaths. One of them was completely unrelated to liver disease. 3 were in the postpartum period in women who had had advanced disease and then flared. When they actually did a comparison of patients who were on and off therapy, and they did not see any increased risk to the fetus in women who were on therapy. What they saw was that women who stopped therapy for pregnancy had an increased risk of flare and lack of disease control. So they concluded that improved disease control prior to pregnancy is important. Cirrhosis is associated with worse outcomes, and that continuing the immunosuppression of the medications that the patient's on, with the exception of mycophenolate, if patients are on that, is relatively safe. There was one other study out of Germany. It was 22 women, 42 pregnancies. 17% rate of spontaneous abortion. The preterm delivery rate was 17%, with the national average being about 6% at that time. And the major thing that they saw was the flare of the disease. And really in the postpartum period, you can see about 50%. They actually compared patients on azathioprine versus not. About 33% of patients stayed on azathioprine. As you can see here, these differences are not statistically significant, but a little bit less rate of spontaneous abortions, a little higher rate of preterm deliveries, but again, not significant when they compared them, and then the healthy children, about 79% in the azathioprine group. So going through your medicines that you may be taking in pregnancy, these are our FDA categories. And I will say that in 2015, the FDA has gone away from these categories, and any new medication that's come out is not using these letter categories, but they're still around for the medicines that we prescribe. Prednisone is Class C. A risk cannot be ruled out. In one study at higher doses, it was associated with cleft palate. In a study where they actually followed patients forward through pregnancy, in about 160 pregnancies, there was not an increased risk of cleft palate. Azathioprine gets a category D. Evidence of risk in some small human studies may be used if the benefits outweigh the risk. And I'm going to go through azathioprine specifically in just a minute for you guys. What I want to say is that larger studies have really shown it to be reassuring. Tacrolimus and cyclosporin, which we use in some patients, are category C. They've been used in transplant patients and are generally safe. And then mycophenolate category D, and it is teratogenic. It's associated with malformations and should not be used. So the azathioprine data. There was animal data from 1967. They administered anywhere from 5 milligrams per kilogram to 20 milligrams per kilogram. Our patients are generally on 1 to 2 milligrams per kilogram. And they showed an increased risk of skeletal abnormalities. There was a study of just 3 patients where they tried to measure if azathioprine was present and did it cross through the placenta. What they found is that 6-TGN, which is the therapeutic metabolite, was present, but at a much lower level, but none of the liver toxic metabolite was actually present. We get a lot of our data from inflammatory bowel disease, where azathioprine is also the standard of care. And they've done meta-analyses, so studies of multiple studies, and they have shown a safety of azathioprine in pregnancy in those studies. There was no association with low birth weight or congenital abnormalities. They did see in one of the studies an increased rate of prematurity, but they didn't account for disease activity, and if the disease is very active, you can see prematurity. There's also been studies in kidney transplant patients and liver transplant patients showing the safety of this. And just, one word regarding the therapy piece of things is I do advocate for continuing it, but that being said, it's a decision between you and the patient, and you have to make a joint decision together. In terms of breastfeeding, my patients have a lot of questions about this, and I want to point you all to a website called LactMed that is produced by the National Library of Medicine. It is a great website. You can go to it. You can put in the medication you're on, and then it'll give you any of the data as to whether it's seen in the breast milk and what are the studies with women who are breastfeeding. And out of this, I think when I was reading each of these individual drugs, I think 169 women were studied who were breastfeeding on steroids for over 3 years, and it was safe, no adverse outcomes. Azathioprine also has been studied. Less than 1% is in the breast milk, and it is cleared after 4 hours, and there were no adverse outcomes to the fetus in that. Tacrolimus and cyclosporin have been studied in transplant registries for over 15 years, and infants have been followed for years out and not seen any adverse effects from breastfeeding on these. Mycophenolate is contraindicated. So, again, I try to really avoid that medicine in any of my women who are of childbearing age. So, my conclusions and what I share with my patients is that successful pregnancies can occur in autoimmune hepatitis, and that autoimmune hepatitis can affect the course of pregnancy, and vice versa. Pregnancy can affect the course of autoimmune hepatitis. The most important thing, I think, is preconception counseling and really getting an understanding from your patient and talking to your patient about the different risks. You really want to stabilize the disease as much as possible. So in the case that I talked to you all about, my patient had just been diagnosed 3 months ago. Her liver test had just normalized. We were still on prednisone and trying to get off prednisone. So what we decided was that let's taper you off prednisone. At least get you, we don't have to wait a whole year maybe, but let's get you a little bit further out from the recent bilirubin of 15 and how sick you were. But she didn't have cirrhosis, and we are working towards, hopefully her having another pregnancy in the future. Close monitoring of the mother and fetus is necessary. I work with my OBs very closely. I monitor labs about every month, and then in the postpartum period, even if patients had been stable before pregnancy, I still monitor them monthly every 4 to 6 weeks for about the first 6 months after pregnancy. Continuing therapy, I think, is safe, and I would think many other clinicians do agree, and many of my colleagues agree. I avoid mycophenolate. But overall, I do think pregnancy is safe, and the most important thing is really just talking to the patients about pregnancy. So moving on to contraception. If I'm going to tell patients that if they have decompensated cirrhosis or their disease is not controlled, that I would like to avoid pregnancy at least at that time, then we have to talk about contraception. When you talk about contraception, you have to think about just in general how effective is the contraception. What are the health risks? So estrogen is metabolized through the liver, and most combined pills contain estrogen and progesterone. And then what are the risks of pregnancy? And that is mainly in advanced cirrhosis. When we talk about effectiveness of contraception, least effective methods include the barrier method, so about 18 or more pregnancies per 100 women per year. The combined hormonal pills, the patch, the ring, about 6 to 12 pregnancies per year. And then the intrauterine devices, either copper or progesterone, and sterilization, about less than 1 pregnancy per year. We do not have specific guidelines within autoimmune hepatitis. The U.S. medical eligibility criteria produces these criteria for cirrhosis. So this is all comers with cirrhosis, not just autoimmune hepatitis, but I think it provides some guidance. And what they say is in mild compensated cirrhosis, any form of birth control is okay. It's a category 1 or no risk. In severe decompensated disease, they say to avoid the combined hormonal contraceptives, so estrogen, progesterone, combined methods, which I agree with that. They give all these other ones a category 3. Theoretical or proven risk usually outweigh the benefit, but they caveat it with there's not really many studies to support this, so you have to use your clinical judgment. And I would say many of my patients with decompensated cirrhosis, I actually advocate for a progesterone-only intrauterine device for birth control. I've found it safe. There's no increased risk of infection. It actually decreases menstrual bleeding. So in patients who have a tendency to bleed, if they have low platelets or their clotting factors are off, it can be helpful. They do give the copper IUD a category 1 or no risk. The only problem in some patients is that it can cause heavy menstrual flow. So if patients have a tendency to bleed, then you're seeing more flow and more anemia. The World Health Organization also gives similar data, basically the same as the U.S. medical eligibility criteria. They do give us some guidance in acute hepatitis or flares. This is all forms of acute hepatitis, so viral hepatitis included. But what they tell us is avoid initiating combined pills in patients who are having an acute flare of disease. If on stable doses, the benefits of continuing usually outweigh the risks, and then there's no restriction regarding progesterone-only contraception. Then patients want to know, do my medicines interact with the contraception? And the answer is, in general, no. Steroids are fine. Azathioprine, there's no interaction. There's a theoretical risk of interaction with cyclosporin and tacrolimus, but it has not been shown clinically. But mycophenolate, which is the one we worry about people getting pregnant on, actually for the progesterone pills or combined pills, there's about a 15% decrease in the progesterone concentration. Doesn't seem to apply to intrauterine devices or the injectables, but it is recommended if patients are on mycophenolate who are of childbearing age that you use either an intrauterine device or some combination of 2 less effective forms, so either a pill and barrier protection. And then moving on to health maintenance. So this is a little bit of a busy slide, but the real point of it is that women who are on immunosuppression need an increased frequency of pap smears. These guidelines are from the American Society for Colposcopy and Cervical Pathology. They were initially developed for HIV, and they've extended them to anyone on immunosuppression, so transplant patients, patients with autoimmune hepatitis who are on immunosuppression. I think they could use some tweaking in immunosuppression, but this is where we are. And the reason we do them more frequently is that there's an increased risk of cervical cancer, and cervical cancer is driven by human papillomavirus. So normally, if you're not on immunosuppression, you start pap smears at age 21. Up until age 30, you do them every 3 years. And then after you get to 30, if you do a test with cytology or the pap smear plus the human papillomavirus, you can space it out to every 5 years if it's negative. And then you can stop when the patient's 65. In immunosuppressed patients, they recommend that you actually start a year after sexual activity or age 21, whichever comes first, and that you do not stop at age 65, and that you actually do them annually below age 30 unless you get 3 negative tests and you can space them out. And then, again, annually above age 30 unless you have 3 negative tests or 1 negative pap smear plus human papillomaviral testing. There is a vaccine now for human papillomavirus. It's recommended for anyone under the age of 26. So if I do have patients under that age, I do recommend they get the vaccine. Patients older than that have probably acquired the virus, so there is no recommendation to give that vaccine. It is a dead vaccine. It's not live, so it is safe in patients who are on immunosuppression. And then there's no difference in mammogram guidelines. There are different guidelines for mammograms in general in all comers. But according to the American College of Gynecology, it's recommended at age 40 and every year, and that's what I generally follow. A word on bone health. Craig brought this up earlier, but I think it's important to address. Many people will talk to their primary care doctor, many women, about bone health once they're postmenopausal, but we need to think about it before menopause and women with autoimmune hepatitis who've been on steroids. So osteoporosis just means reduced bone density and bone quality. And it's an increased risk of fractures, mainly at the spine, the wrist, and the hip. The risk factor is really menopause in women. The lower estrogen is associated with decreased bone density and increased bone turnover. Any history of a prior low trauma fracture, steroid use, as you see here, and then a lower body mass index. We can actually measure bone density through what's called a DEXA scan or dual energy X-ray absorptiometry scan. And this scan then gives you two numbers. It gives you a T-score, which compares you to a young adult reference population. And if this is 2.5 standard deviations below the mean, labeled as osteoporosis. We'll also give a Z-score, which actually compares you to age-matched controls. This T-score has been standardized in postmenopausal patients. It's thought that maybe we should start considering this in premenopausal patients, although the guidelines don't have it in there yet. So this is just, I put together some guidelines from the American Gastroenterological Association, and there's actually a good article on autoimmune hepatitis and bone health. So if patients have autoimmune liver disease and they're on prolonged steroids, and they define that, they've actually looked to say, is it 10 milligrams, is it 2.5 milligrams, and we don't know. So they've said 7.5 milligrams or more for 3 months. Basic prevention. So I ask my patients to make sure they're taking in about 1,000 milligrams of calcium a day and about 400 to 1,000 units of vitamin D. I check all my patients' vitamin D at least once a year and replete it if it's low. Smoking cessation, avoiding heavy alcohol use, and then encouraging weight-bearing exercise. Do that for all the patients. Then you go down this, have they had a history of a low trauma fracture? If they have, we probably just want to treat with a bisphosphonate, such as alendronate. If they haven't, then we measure bone density, even if someone is premenopausal. If it's normal, then I work, like many others, to get patients off steroids in general. And then you repeat it in 1 year or every 2 to 3 years while patients are on steroids. If there's osteoporosis, you treat. It's the difference in this osteopenia, which is reduced bone density, but still not osteoporosis, where normally we may not treat, but in patients who are going to stay on steroids, we'll actually consider treating. There's something called a FRAX calculator. Again, you can Google this, and it's meant for women who are 40 or older. You put in age, you put in weight and height, you put in whether patients are on steroids, it's 5 milligrams or more a day, and secondary osteoporosis, and they say that liver disease is included in this. And then you put in what the T-score was from the bone density scan, and you get a number. So I plugged this patient in. She's 66. She didn't quite meet osteoporosis. And it gives you this 10-year probability of a hip fracture or a major osteoporotic fracture. And it's felt that if the hip fracture probability is greater than 3% or this major fracture greater than 20%, then you should probably treat. And at the bottom, they caveat that it is a individualized clinical decision, which I agree with. So just something to think about for those patients who are not clearly osteoporotic but have reduced bone density. So in conclusion, pregnancy is safe. Counseling is really, really important. And continuing therapy is safe. And you really have to watch for postpartum flares of the disease, even in patients who were controlled prior to pregnancy. Lactation, I advocate that you take a look at the LactMed site when you're thinking about breastfeeding. Most of the medications, with the exception of mycophenolate, are safe. In terms of contraception, I avoid the combined hormonal estrogen-progesterone pill in patients who have advanced decompensated disease. And in terms of healthcare maintenance, just thinking about with your primary care doctors that there is an increased risk of cervical cancer, and we should do pap smears more frequently in women who are on immunosuppression, and that we have to be a lot more vigilant about bone health in women who are on steroids. So I want to thank some of my colleagues at Duke, as well as my mentor, Dan Pratt, at Massachusetts General Hospital, and all my patients and caregivers who've really taught me what I know about autoimmune hepatitis and taking care of women and pregnant patients with autoimmune hepatitis. I will be doing a breakout session on pregnancy and autoimmune hepatitis later this afternoon, and I'm happy to take questions and chat about it further. Thank you.